I'm going to talk to you a little bit about a remplissage. You can see my posterior portal. This is a left shoulder cadaver. There's my acromion, there's my spine and my scapula, and I actually put the scope in where I usually go. This would be for my interarticular view typically, but I like to be just a touch more laterally when I do anterior instability surgery. So although I started here, I did change this around, and I did that based on what it looked like on the articular view. Anteriorly, there's the acromioclavicular joint, and I have my portal in front of that, and that should be parallel with the glenoid. And so these two portals will get me started, and then if I needed an anterior-inferior portal, clearly I come down to the coracoid process and then come more lateral, and that would be for my Bankart operation. But the purpose of today was to try to create a remplissage as best we could. Your supraspinatus, your biceps insertion, your subscapularis a little bit, degenerative superior labrum, and then you sweep down. When you want to come in here, you come in the front. You can lift the humeral head. This is the best way to get your view of your anterior-inferior from this portal. And then when you want to start looking at your Hill-Sachs lesion, you start sweeping the camera backwards. But this bruise here will become your posterior lesion. So now here we are from the anterior portal looking posteriorly. That would be my lesion if I had a Bankart lesion. Again, many times the humeral head is out the front or partially out the front in these unstable cases. Now as I sweep, that's where we created the Hill-Sachs lesion. This would potentially engage if I externally rotate and translate the shoulder. You can see it's coming in contact with the posterior glenoid. It's nice to know where it is relative to the glenoid before and after, because you want to know that this lesion doesn't, even if you don't do a remplissage, you'd like to know that this does not come in contact with the glenoid. I start off with my cannula actually in the joint. And the first thing I want to do is see what kind of quality. You can measure it, you can reduce it. Your assistant may push on the humeral head to reduce it, and now you want to make a hole. And I'm one of the people who like a single anchor as opposed to two anchors because I worry about the bridge of bone being soft. So typically I'll come right through my portal, and I'm going to try to get as perpendicular. Now, as this defect starts becoming more medially, you cannot put anchors down here. Number one, you might actually perforate the head and come out the front. And number two, you're not going to be able to grab a tendon of the infraspinatus if you start coming down this low. You more than likely will get the muscle, and I worry about the potential disruption. Remember, the purpose of this is to tension the infraspinatus and capsule into the defect, and you cannot bring it all the way down to that aspect of the shoulder. And so we're just going to get the hole started. It doesn't have to, the beauty of this anchor is it doesn't need a full perforation. I also get a feeling for the quality, a couple more, quality of the bone based on this. If this just falls into an empty egg, I know I may have an issue. Also, when it's hard bone like it's now, I may want to go all the way down with the black line to the bone. And I'm going to basically use a rotator cuff anchor. It's a 3-stitch Y knot. It's all-suture, so it looks a little different for those that are not familiar with it. Try to follow your line, your angle, and your insertion so it doesn't fold. First couple taps are soft and get it engaged. And you're going to go down to that line. Now you have to load the anchor up to pull it back to the edge of the hole. You can see it sliding through the cannula a little bit. What is happening is this anchor is bunching up inside the hole. Now, the other thing I like to do is sometimes slide the sutures just to make sure everything's sliding at this point. The other technique here would actually be to make percutaneous, but if you came in, let's say, from a different place, you could kind of get a dress rehearsal of what you want to do. Now, that would be coming in almost parallel with your anchor. Ideally, you'd be coming in more lateral to your anchor, like this. And the reason is, now when I tie it down, I will be on tendon and not muscle. And I'm also taking the more lateral tissue and pulling it into this defect. So I'm mobilizing it just like you do the Bankart inferior to superior. I'm trying to come in from an angle lateral to medial. So if I do it percutaneously, I could certainly take this technique, spinal needle, pass shuttles in, and pull the sutures out. But for today, we're going to do it a little bit different and maybe a little quicker and easier. But I'm going to use the Raven. It's a straight instrument. It's relatively small. And what it's going to allow me to do is work from outside to in. If I came straight in before, this is what that instrument looks like to you. Now I'm going to pull out and I'm going to try to mobilize where I was with that spinal needle. and I'm going to pierce the tissue, but I want to be inferior to my anchor. And so now I'm going to take this and I'm going to try only to pull. If you can, I want to stabilize the other arm of the stitch so I don't by mistake pull it out. This is a little bit more restricting than the percutaneous technique because you're trying to work through your cannula. So now I'm going to go a little bit more superior and grab the other arm of that same stitch, and hopefully this creates a little bit of a better situation. The next one, I'm going to just force myself to get anteriorly a little bit more, and now I'll take the other half of this blue stitch. So now the mattress suture is still being retrieved because everything's being done through my cannula. We should have now 2 mattress sutures, one anteriorly and the black stitch posteriorly. So for me, that blue stitch is a little bit of a bonus, but let's not waste anything. If we really thought we had it all covered, we could pull that out. You can see how everything is now lateral. There's your original portal. There's your stitches. And you can imagine what's going to happen. Now, I'm just going to show you one trick. But every once in a while, when you do posterior stabilization, you say, I don't really like the hole in my capsule there. So here's just a quick technique on that. Come in here on one side of my cannula hole, drop my stitch off, come on the other side of the portal hole. So when I do posterior stabilization, I actually close my portal this way. So we use these techniques, for different operations. So that would close my posterior portal on a posterior stabilization. So I like closing the portals, at least the posterior capsule portals. The ones in the interval generally are not too important to do. So now all your sutures are in your camera and in your portal. So I'm going to start with the most inferior, which was the first ones I put in, which are the black stripe ones. And so I'm going to tie from inferior to superior, because once I tie that superior hole, I won't see the rest of the operation from this perspective. When I do this in real life, I don't necessarily rush and cut my sutures, because when I'm trying to do my anterior bankart, I now have a wonderful Fukuda retractor in there, meaning my sutures pulling back the humeral head. So I just closed my most inferior hole, and I'm just going to work my way up from inferior to superior. You can see how things are coming up and closing into the hole. And so this is blind tying of the knot. The other way of doing it, like I said earlier, would be to do a little bursectomy, then put the spinal needle and shuttle the sutures through, and then go into the subacromial space and visualize you tying the knot, but then you can't see the tissue going into the defect like you're seeing it now. So here's what it may look like. There's your posterior corner, there's your labrum. That would have been your beginning of your bankart, maybe at 6 o'clock there. There is your tissue invaginated into your defect. There was the posterior capsule closure, unrelated to this pathology. And then you could kind of move the humeral head and see how your tissue is really tied into this. That side-to-side stitch was not necessary for anterior instability, but maybe posterior. So remember, lateral to medial. So I want tension there, but I need some capsular laxity here, because if I have that so tight, then I've restricted the range of motion quite a bit. One more thing, outside-wise, I want to just show you, come around the corner, where you go for that 6 o'clock anchor. So here's my posterior portal. It's going to be not necessarily inferior, but more lateral to this. This is a separate portal. Remember that white stitch was your posterior portal, and look what I could do in terms of getting to 6 o'clock. So I'd mobilize the tissue first. If I was going to put an inferior capsular suture in, I'd put it in second, and third would be my remplissage step, and then I'd do my anterior inferior bankart in that order. Thanks for your attention.